Yeah, I think we can get started. Like I said, I'm William, one of the residents here. I'm just going to give a brief introduction for Dr. Bennett, and then I'll let her take over. So Raquel Bennett, she's a PsyD, she's a psychologist and ketamine specialist out of Berkeley, California. Works primarily with people with severe depression, bipolar disorder, suicidal thoughts. She's really fascinated with the antidepressant, anti-obsessional properties of ketamine. She's been studying these for quite a while, at least 2 decades. And is really interested in the psychedelic and mystical properties of the substance as well, and how it could be used for spiritual exploration. She's the founder of the Kriya Institute and the Kriya Conference. These are both dedicated to ketamine use in psychiatry and psychotherapy. And she's given many, many lectures and trained thousands of clinicians in the safe and legal use of ketamine. We're very thankful to have her here today, very excited to have her here. She'll be talking to us, and then afterwards we'll do the Q&A. So with that, I will turn it over to Dr. Bennett.
Oh, thank you so much. I'm honored and delighted to be here. Thank you for having me. Before I even get started, I really wanted to express my thanks to Dr. Pruitt and also to Dr. Sloshower, Dr. Pruitt for hosting today, and for Dr. Sloshower for inviting me in the past. You may know that this talk is a follow-up to a talk that I gave in 2019, and so I'll be referencing that talk as well. Before I dive in, let me tell you a little bit more about my work. I think we covered it. Just to say that I'm out here in Berkeley, and I work in collaboration with physicians, which is what makes it possible and legal to do this. I have no disclosures or conflicts of interest of any kind. So I think that just about covers it. Okay, so today, the premise of this talk is that ketamine is a flexible tool and that it can be used in a variety of ways, and that all of the ways have merits. All of the different routes of administration and all of the different dosing strategies are useful some of the time. And so that's the essence of what I want to talk about today. And I want to talk about ways of using ketamine that are newer and that will expand what's happening in the field. So last time I was here, as I said, I was here in 2019, and that talk is available for free on YouTube. It's not a bad talk. I encourage you to take a look at it. And in that talk, in the previous talk, we covered, I talked about the chemistry of ketamine, and with an emphasis on the fact that it's a chiral molecule. That the talk explains what that is. We talked about the clinical indications for ketamine treatment. We talked specifically about who makes a good candidate and who makes not such a good candidate for ketamine treatment. We talked about the safety of ketamine, and I emphasize that there's really 2 components to safety in ketamine treatment. Part of it is the medical or physical safety of the patient. That's of course an important consideration. But also we need to be talking and thinking actively about the psychological safety of each patient. I think that gets overlooked or not talked about enough often, but it's really important, equally important for sure. So we talked about that. I also talked about side effects of ketamine. We talked about the fact that ketamine is an adjunctive treatment, meaning that in the way that I think about it and in the way that we use it adjunctively or in addition to other kinds of interventions, including psychotherapy and oral medication, and all the free stuff, mindfulness meditation, being attentive to what patients are putting into their body in the form of food, being attentive to sleep schedule, exercise, sunshine, all the other things that people can do on their own that are free. All those things contribute, I think, to a good clinical outcome. Then I talked about the legality of ketamine, and this is a particularly confusing area. And I'll just make a few comments about that now. The confusion about ketamine treatment and its legal status is rooted in the fact that there are different agencies, and each of them have a say in how we think about ketamine treatment. So you know that ketamine is in Schedule 3 according to the DEA. And so in that sense, it's legal for clinicians to use. However, as you also know, if there's a concern or a complaint, the cases are adjudicated at a local or regional level, not at the national level. And so it's really important that whatever you do as a clinician is defensible in front of the board. And if the board has a question about what you've done, they're going to turn to the research literature, to the scientific literature, to see if there's support for what you did. And I just want to point out that there have been some cases where, although ketamine is in DEA Schedule 3, the board in whatever state did not agree with the clinician's decision making, and that created a problem for the clinician. So again, it's really important to know what your board is, what their position is. It's important to know what's in the scientific and research literature. The literature is evolving very rapidly, which is exciting. And so we can come back to this question later, but I just wanted to point out that this is where the situation is not as simple as one might wish or hope. So anyway, we talked about that. And finally, last time I was here, we talked about the different paradigms for ketamine treatment. We talked about different ways of conceptualizing the treatment. And do I want to talk about that now? Sure, I can talk about that now. Let me recap that, because I think it's really important. And I think it's really the foundation for all further conversation about therapeutic ketamine. So here's the thing. The thing is that there's really sort of three different ways of thinking about the clinical treatment of patients using ketamine. And here they are. One of them is a biochemical model. And the hallmarks of this model is that the clinician or the researcher is focused on what ketamine is doing at a cellular or even molecular level, or with respect to brain regions and brain anatomy and other biochemical considerations. And in a biochemical model, people focus their attention on what the medicine is doing at, as I said, at a biological or biochemical level. But often little attention is paid to the patient's subjective experience or to the psychological processing of their experience. The setting often is not considered an important variable. So here all the emphasis is on what's happening, as I said, biologically or biochemically. And it's important to note that most of the research that's been done has come out of a biochemical paradigm, where psychotherapy is neither encouraged nor required, etc. And also where the psychedelic properties of ketamine, ketamine has prominent dissociative and psychedelic properties. But where the psychedelic properties are typically in the research considered problematic. They're a problematic and annoying side effect to be avoided. And in the early research about ketamine, they recommended that you dose below, you dose underneath the psychedelic properties of ketamine so as to avoid any alterations in state of consciousness. So that in a nutshell is what the biochemical paradigm is all about. And as I said, we talked about it at length in my previous talk. But that's not the only way to use this tool. Another way to use this tool is to use ketamine as an adjunct to psychotherapy. That's a psychotherapeutic model. So that's where you're using ketamine as a catalyst or a lubricant for the psychotherapy process itself, and where the emphasis in the treatment is actually on the psychotherapy dialogue. In other words, the emphasis is on the verbal metabolism of emotional material, using ketamine to lubricate or to aid in that process. Again, here, the emphasis is on the psychotherapy. And just as a side note, this is really similar to what MAPS is doing with MDMA, where you're combining a powerful psychoactive chemical with psychotherapy, thinking that both components are important. So we talked about that. Just as a note there, from my perspective, when I talk about ketamine facilitated psychotherapy or ketamine assisted therapy, what I mean is that the dose is still low enough so that the patient, you don't want the dose to be too high, because you need for the patient to have the capacity to be meaningfully engaged in the psychotherapy dialogue and to be able to engage in self-reflection or self-awareness. And if you dose up, which we're going to talk about, then the patients, it becomes more difficult for them to track their own thoughts, and they sort of lose interest in engagement in therapy. So the next paradigm that I want to talk about, the third one, is doing ketamine psychedelic journeys. In other words, making use of the prominent dissociative and psychedelic properties of ketamine, not shying away from that, but rather using the ketamine on purpose to invite or induce mystical type experience, with the belief that the visions themselves, the visions that could arise, that those are potentially beneficial and valuable for the patient. So just thinking about that for a minute, in the first two paradigms that I described, the biochemical one and the psychotherapeutic one, there you're trying to essentially avoid the psychedelic properties of ketamine. But in the third paradigm, in the psychedelic paradigm, the psychedelic properties are considered part of the main action. That's the psychedelic properties are desirable. So here we have three different ways of conceptualizing ketamine treatment, and clinicians in the field are utilizing all three approaches. Let me just add, just for the sake of being complete, that in reality, these different paradigms blend together in clinical practice to some degree. It's useful to be able to articulate them separately, but in reality, let me give you an example. If the patient comes in and you decide that they would be a good candidate for psychedelic treatment, the reality is that the patient is getting an effect on a biochemical level, and the whole experience is wrapped in a psychotherapeutic process with a lot of attention to relationship and frame and the therapeutic alliance, and the patient may experience visions. And so in that sense, all three of the paradigms are used together in a way that's unavoidable, and I think that's desirable. So that makes it more complicated, but I think you get the essence of what I mean. Anyway, in my last talk, we reviewed some of the common contents and themes that come up in psychedelic ketamine journeys. And I noted that there were a couple of different variables in clinical ketamine treatment. And so I'll just repeat those here. There's 5 variables, 5 things that the clinician can adjust or control as per the patient's individual needs. And those 5 variables are, number 1, the route. How are you putting ketamine into the patient's body? Number 2, the dosing strategy. How much ketamine are you introducing or administering at any given time or in a single session, and why? Number 3 is the frequency. How often are you doing this and why? Number 4 is the setting, which is a variable that I think is really underappreciated, but it turns out that it's really important in the use of visionary medicines like ketamine and all the other ones that are coming. Patients, they tend to open up to the experience, and they seem to make the best use of it when they feel safe and comfortable, and that's very intimately tied to the physical setting, also the relational context. And finally, I said there were 5 variables. The 5th one is clinical presence. That means the person who's providing the ketamine or who's physically present at the time of the administration. How do they understand their job? What is it that they think they're supposed to be doing while the patient is having the ketamine in their own body? And so are they focused on medical monitoring? Are they trying to provide concurrent psychotherapy? Are they sitting back and imagining themselves more like an unintrusive psychedelic guide? All of the above. But anyway, that's a critical variable in the treatment. The provider, how do they understand their role in the room? Is there even somebody in the room? That's another question that creates more challenges and complexity here. In any case, we recapped, as I said, we talked about these things in 2019. Please check out that video. It's free. And so with that, let's move on now to the new material for today. Here's what's on my agenda. I want to talk a little bit about working with groups and ketamine. And then I want to talk a little bit more about esketamine and some of the opportunities and challenges there. I'd like to talk a little bit about the ethical guidelines, and then I have a bunch of other stuff, and we'll see how far we get. So let me just keep going. I feel obligated to say that this is not a comprehensive training. There are lots of trainings available about ketamine. Ava, my assistant, if you would kindly put the link for trainings in the chat, that would be great. And just to say that I'm not currently doing any training. These are trainings that are offered by colleagues that I respect. Okay, so moving right along. So I think a really important question in this moment right now is how we're going to increase accessibility to ketamine treatment. The reality is that it's quite expensive, and that's a problem. So there are some things that we can do as clinicians right now to increase accessibility, and those things include using generic racemic ketamine as much as possible. That's something we could do. Personally, I sort of favor injectable ketamine in our clinical partnership. It's cheap, it's easy. All medical professionals know how to give an injection. Not all medical professionals are comfortable starting an IV, and I'm not convinced that that's actually necessary here. We can, in terms of increasing accessibility, we can offer more group work when it's clinically indicated or when it's clinically a good fit. We can train more people to use this tool in a skillful way. And then ultimately, we need to be working toward FDA approval of generic ketamine or racemic ketamine for a mental health indication. And we need to work together to do that. Anyway, let's talk about group work. Group work can be really lovely and something that's not in the literature much yet. But let me start with this. Every single patient that goes into group ketamine treatment still goes through all four of the essential steps of ketamine treatment that would be the same for individual treatment. And so those four steps are, number one, patient selection, making sure that the patient is appropriate to ketamine treatment and is likely to benefit from it. Patient selection, and being really judicious about that, number one. Number two, patient preparation. This experience can be very strange and unusual. As I said, ketamine has prominent dissociative and psychedelic properties. And so helping patients to be prepared for what might come up is really important. And if you want to learn about that in greater detail, please think about taking a training. Anyway, that's the second step, patient preparation. The third step is the ketamine administration itself, the actual medicine session or sessions. And finally, there needs to be some follow-up care with ketamine because it's a unique and unusual tool. It's not like your regular, oral, pharmacotherapy agents. So anyway, those are the four essential steps. They're the same in group treatment and in individual treatment. And as I said, we favor injectable racemic ketamine. We like it because it's cheap and it's easy. It's very precise, has good bioavailability. Is there anything else I want to say about that? No, I think that's it. You can administer ketamine using in any dose. It can be a tiny dose. It can be a more substantial dose as per your clinical judgment. In group work with clinical patients, I prefer small groups. That's my preference. So usually it's 2 clinicians, so a medical professional and a mental health professional working together as a collaborative team. And my preference is to see 4 to 6 clients at a time. 4 gives like a nice, helps create a sense of group and community. 6 is kind of like the max that I feel comfortable with just 2 providers. And my thinking on that is that if one client needs attention or assistance, they're not feeling well, their experience is, disorienting for them, they need assistance navigating their way to the bathroom, then that leaves one other provider to attend to the other 5 clients. So I'm aware that some folks work with large groups, bigger groups of patients. That's not something that I have a lot of experience with. So anyway, I prefer small groups. And one of the things that I like about it is that it makes it possible to have a cross-disciplinary collaboration. So there, as I said, you have a medical and a mental health professional working together. And I think that's a really sweet combination. And I think that's actually advantageous for the patients. So I prefer to do this as a series. And I think that like 4 sessions is a good number when that's possible and when that fits with your clinical practice. And here's why. It's really sweet when the group coalesces into a little, they get like a group dynamic going, and there's a sense of care and familiarity with the other group members. And it takes, at least 4 sessions for that to solidify in my experience. So I prefer a series over individual, one-offs when that's possible. And in terms of timing, my preference is to have groups meet for ketamine treatment about once a month. I like to have them spaced close enough together that there's a sense of continuity or cohesion within the series. But it's also important to leave enough time in between each session for people to meet with their individual therapists, which is not necessarily us, and to process whatever has come up or to sit with it, and also to get ready for the next session. So there's another way of saying the same thing is to say that there needs to be time for preparation, medicine, and integration for each session. I think that's what works best. Just again, in my experience. And as I said, there are some significant advantages to ketamine group work. Of course, the first thing that comes to mind is that it reduces the cost. It can dramatically reduce the cost of ketamine treatment for each individual client, and in that way increases accessibility, and that's a good thing. But there's more to it than that. Having multiple sessions, like what I described, takes the pressure off of each session. It feels more spacious, so that the clients can feel comfortable. They don't feel like they need to get the one thing they need to get in like the one session that they can afford, but rather it's okay for it to manifest the work or the effect to show up over time. And if this first session wasn't perfect, that's okay. We can adjust the dose, and there's still time to let the medicine be clinically effective and to sort of see what it has to offer. So I like that spaciousness that group work often makes more possible. And it helps people to get familiar with ketamine in a more gradual way. Often you can, dose a little lower and then kind of work your way up as clinically indicated if needed. But some of the other advantages of group work is that we've learned that, as you know from doing other kinds of group work, that it's often really helpful for individuals to feel less alone, like they're not the only person who's having a particular issue or problem, but rather that there are other people who are grappling with similar kinds of concerns, and people tend to feel less isolated. And that's reassuring and comforting, and it has clinical value, I think. And beyond that, sometimes clients who are in the same group go on to become friends. There's a social component, and that can be very sweet. And I think just enhances the clinical effect. Yeah, I mean, I guess I would add that people tend to have bigger, more powerful, more impactful experience as they become more familiar with ketamine and more relaxed. And so there's something about the spaciousness and the unfolding that I think we haven't talked about enough in clinical ketamine treatment that I think is actually really important. That said, there's a couple of challenges with group work that I want to name. So the first challenge is that not every individual is well suited to group work, and people tend to want group work because it's less expensive. But it's really important to be able to be able to hold the limit as the clinician, and to let people know when you think that they need the clinician's undivided individual attention, and to make sure that clients get that when needed. And this is particularly I think this is something we need to be thinking about, particularly when clients are dealing with a lot of historic trauma. They tend to need more of the clinician's attention in general. And so I'm cautious and thoughtful about putting people who have a lot of trauma into a group unless the focus of the group is processing trauma. And I'll say more about that in a moment. But anyway, I was saying the challenges of group work is, number one, being able to hold the line when people would benefit more from individual treatment. Number two, you may not know the group members as well. And that can sometimes be challenging, especially if you're not seeing them for individual treatment, but rather they're in treatment with somebody else. Another challenge is this question of dosing. I think it works best when clients are working in a similar dose range. So either in a talking or psycholytic dose or in a psychedelic dose. But what doesn't work well, in my experience, is when you mix them, some people are popping out of their ketamine experience sooner than other ones, and then the group sort of feels uneven. So being thoughtful about that, I think, is helpful. Another way of saying the same thing is the following. I personally prefer homogeneous grouping. That means putting people together in the same group who are similar either in their level of acuity or the severity of their distress, or similar with respect to their diagnosis. Yeah. And I have not personally had good success in what's called heterogeneous grouping. So putting people together who are kind of in really different places or working on different things. So I've been told by friends and colleagues in the ayahuasca community that they mostly do heterogeneous grouping. I've never done ayahuasca, so I might not be the best person to ask about this, but I'm just going to try my best. So in some kinds of sacred medicine work, the idea is that you just take all comers and whatever anybody's got going on, that's their business, and that people just find a way to work together, and each person is doing their own work in a group context, and it doesn't matter that much what somebody else is working on. And that may be true for other kinds of medicines. But as I said, that has not worked well for me with ketamine treatment. So just something to think about, and I'd be really interested to hear other people's experiences, as we go forward and as more people try to do this. So I think those are my thoughts right now about group work for patients. Let me switch gears for a second and talk about group work for trainees. So giving experiential training to trainees who want it. I think it should be offered. I don't think it should be required. Here's the thing. There's no doubt in my mind that it makes people better clinicians, more compassionate and more comfortable and more skillful if they have direct personal individual experience with things like ketamine, which it's just, I can't think of the word I want, which is funny. It's ineffable by definition. The ketamine experience is hard to describe and hard to know that terrain unless you've experienced it directly. And I also think about the psychoanalytic model of training clinicians, where being the client or the patient is equally important to your credentialing as being the provider. You learn so much by seeing what it feels like to be vulnerable and to explore these intimate spaces from the client's perspective. I also think a little bit about the shamanic model for working with sacred medicine. I think of ketamine as a sacred medicine, also as a pharmaceutical, but also as a sacred medicine. So from a traditional shamanic perspective, each provider needs to be invited or be allied with the medicine. The medicine has to invite you or call you to want to work with it. And I think there's something valuable there, having a relationship with the medicine. Having a personal relationship, I think, is important. Something that we don't embrace so much in the medical model, but I do. Ketamine is not your typical average medicine. So I think it's worth looking at the indigenous other traditions to see what they have to offer, what they say about this. I'll share something personal. My father was a physician, now deceased, and he had cancer and had multiple surgeries at the end of his life. And I remember him telling me that he wished that he had spent a week in the hospital as a medical resident, that he would have practiced medicine differently if he had known what it felt like to be in the hospital, to be the patient, and to be scared or uncertain, and to see it from the patient's perspective. And so that comment stayed with me, and I think it's relevant here. How can we improve our clinical treatment? How can we provide the best care possible? I think one of those ways is to understand from the patient's perspective what it's like to be ill or in distress. Finally, I wanted to point out that my colleague Pam Kriskow has a new paper coming out about the use of ketamine in a group setting to help clinicians cope with professional burnout. For a variety of reasons, this is particularly important now in a time of COVID, when it's been so stressful to be a medical or mental health provider. So please keep your eye open for that paper coming out. She has a program called Roots to Thrive out of Vancouver, Canada. I hope something similar will be implemented here. Anyway, some further thoughts on working with groups and trainees. Here's the thing, it's important, it's essential that the trainer or the provider, that everyone is attentive to all pertinent federal and local regulations and laws. And so by that, what I mean is we treat our trainees, we intake them the same as we intake patients. Meaning that there has to be something there that we can treat, and it has to be justifiable to give ketamine. And if there isn't anything in the history, then we can't offer that kind of training because that's not legal. And so that's always something that we have to contend with. But in essence, working with trainees is very similar to what we do with patients. We often work with groups of 4 to 6 clients or students with 2 trainers or providers. We work with injectable ketamine. We usually provide 4 sessions for each cohort. We like to space our experiential sessions about a month apart for the same reasons I said before, to allow for processing of the material that has emerged. Here's the thing, there is a critical difference between training and treatment. And here's what it is. In treatment, patients get the route and dose and frequency that they need. So those things are determined by the patient's needs. But in training, we have our own idea about what we want the students to see. And so as trainers, we're choosing the route and the dose that we want to show. And in that sense, it's not treatment. It's not the same as clinical treatment because we have our own preset agenda of what kinds of experiences we'd like for the students to have. So important distinction between training and treatment. They should not be confused. And so yeah, what we actually do is we do a grand tour in our 4 sessions, starting with lozenges so that the trainees can experience that and have a chance to talk with each other under the influence of ketamine. And that's meant to give a sense of what it might be like to be the patient in a ketamine facilitated psychotherapy. And then we move to injectable ketamine for the remaining 3 sessions, starting at 1.0 milligrams per kilogram, which is considered the entry to psychedelic experience with ketamine, and then moving up from there, progressing up. And so we usually stop at 1.25 or 1.5 milligrams per kilogram. And we, just as a side note, we never go above 150 milligrams of ketamine IM in an outpatient setting because we don't see the value in that. And we believe that the risk goes up as the dose goes up. And so we like to keep the dose in a psychedelic place, but not going too high, just because we like to be conservative with respect to with safety. Another thing I wanted to mention here is that some trainers offer multiple ketamine sessions in like a weekend or a week. And I understand the thinking behind that. That's for logistical reasons and to accommodate people who are flying in from out of town. And so it's important to get as much information in there as possible. But what's challenging about that is that it often doesn't allow enough time for the participants to process what's happening. So from logistical considerations aside, from my perspective, it's ideal to be meeting in a cohort that meets multiple times that's spread out. But as I said, I understand that that's not always possible. So somebody asked me how many journeys is sufficient to be trained or to really have a sense of what this medicine can do. And I'll respond to that by saying that I think 3 or 4 should be the minimum, in my opinion. And here's how we do it. We do something called the Bennett trio, which is if a person, if an individual, a student or a patient is truly a good candidate for psychedelic ketamine dosing, and not everybody is. But if we were going to go into the psychedelic dose range, here's how we're going to do it. In the first session in a trio, in the Bennett trio, I think it's useful for the patient to have, or the participant to experience a little under the dissociative edge, a little under 1.0 mg/kg, could be 0.75, 0.8, somewhere in that range. And the purpose of that, the reason that I want to dose it that way, or the reason I'm going to make that recommendation to my team is because I want the patients to be able to communicate back with us as needed about their experience. And I also want them to be able to hear us if we make any suggestions or give any guidance. So I want to start a little under the full psychedelic range for that reason. That's number 1 of the Bennett trio. Then when patients come back, by the way, I'm using my hand to indicate that this is the 1.0 mg/kg, where patients enter into a K-hole and essentially lose interest in external stimuli. First session is going to be a little under. Second session is going to be a little over or into that range, so that people can have a full dissociative and psychedelic experience if we've agreed ahead of time that that's useful and appropriate. So session number 2. And here's the interesting part. In session number 3, we tend to repeat the same dose that was administered in session number 2. We don't need to go up in dose. But participants predictably and reliably have bigger and more expansive and more beautiful or more meaningful experience, I think, in that 3rd administration, despite the fact that there's no change in dose. Why is that? Because ketamine is one of these medicines where you have to feel safe and you have to relax and open your body. I think that works the best, to open your body and open your psyche to the experience. And I just haven't found a way to shortcut that. It works differently in session number 3 than it does in 1 or 2. And there's plenty of anecdotal support from the clinical community to support that. So I think that's worth keeping in mind. As I said, we tend to do 4 sessions. So 3 or 4, I think, is a good number. Those are my thoughts on that. Do I have anything else I want to say about group work right now? By the way, the thing I just said about the Bennett trio is true for individual work or group work. It doesn't matter. But since we were talking about doing a series, I thought that was a good thing to bring up. Anyway, I hope that that inspires you to potentially want to work with groups. Let me change subjects in the interest of time. Let's talk about something else while we're here. I want to talk a little bit about esketamine. Esketamine being one of the 2 enantiomers of racemic or generic ketamine. You know, it's a mixed bag with esketamine or with individual enantiomers, in my opinion. So you probably know that esketamine, an esketamine product, got approval from the FDA to be used for the treatment of depression in 2019. and is being looked at now for treating suicidality. And I think there's some interest in looking at it as a treatment for schizophrenia and a number of other things. So that FDA approval, there was some good news. That FDA approval that happened pushed the whole field forward in a couple of significant ways. So first of all, it established what we already knew, which is that a ketamine product is safe for use in an outpatient setting. It established that. We knew that, but okay, good to have that in writing. And would establish that ketamine or a ketamine product or a ketamine related molecule, a component of ketamine really is, it's effective for treating severe and refractory depressive disorder. We knew that, but good to know. It established that it's really not necessary to have an anesthesiologist present for the ketamine administration. That's not required. Sometimes we send patients to anesthesia providers when they are medically complicated, but their presence is not actually not necessary in this FDA approval. And it also in order to give patients esketamine, they have to be taking another oral medication. Some patients can't do that or don't want to. But what I like about this, or the significance of this, is that it established that a ketamine product by itself is not sufficient. It's inadequate for treating a depressive disorder. And I actually believe that to be true. I think of ketamine as an adjunctive treatment, not a standalone treatment. And so this FDA approval for the esketamine product demonstrated that. I don't know that people necessarily need to be taking a specific oral, another medication, but it does make the point, and this is what's relevant to us, is that combining ketamine with other modalities, I think, is probably the most effective and the way to go. And so that was demonstrated there. Okay, so that's the good news about esketamine and its development. There's some not so good news about esketamine and its development. Let's talk about that next, namely the cost. So you probably know this already, but in case you don't, I'm just going to tell you that for the medical supply alone, not the provider's time, but just for the supplies, racemic generic ketamine, broadly available as a medical supply, about $1.59 right now for 100 milligrams. So less than $2. Less than a soda or a cup of coffee for the generic or racemic ketamine. Dirt cheap, in other words. And for 84 milligrams of esketamine, that's going to cost you or your insurance $850. I mean, whoa. So one would hope that esketamine was somehow more clinically effective or something than the generic alternative. That is not the case. Ava, can you put up for me those two links showing that esketamine was considered non-inferior to racemic ketamine in a clinical study? And then there's another study that showed that actually racemic ketamine actually had slightly better clinical results than esketamine in a head-to-head trial. If you would put that in the chat, that'd be amazing. Anyway, I know it's controversial, sorry, but somebody has to say it. Let's see here. Okay, so esketamine and those products, that's great. If insurance will cover it, that's wonderful. Insurance coverage, I'm happy for that. Problem, the pharmaceutical company essentially controls the routes, the dose, and the frequency of treatment if you're going to use esketamine. But in contrast, if you're going to work with generic racemic ketamine, the provider gets to exercise their clinical expertise and clinical judgment, and the clinician gets to choose the routes, the dose, and the frequency of the treatment. And I think that's a real advantage. So something we should be talking about. Do I have anything else I want to say about it? No, I think I said enough. Let me leave it there on that topic. Let me just look at the time. So anyway, I really hope that we can ultimately get an FDA approval for racemic ketamine for a mental health indication. The reason that we need that is to get broad medical insurance coverage for this treatment so that it's, as I said, becomes more accessible to more people. That's really the whole point of all this. I'm not convinced that any single enantiomer performs better than the existing generic. So I'll go on record on saying that. Okay, I have a number of other things I'd like to touch on today. I'm so happy to be here. I want to talk for a second about the ethical guidelines for ketamine clinicians. And if you could put up the link for that, that'd be great. So in 2020, I published in a medical journal a very brief document called the Ethical Guidelines for Ketamine Clinicians. It's only like a page and a half long. And it's the only document of its kind on this subject. And it's worth noting that this particular short document is currently being used in inquiries to the board in various states, and also being used in medical malpractice court cases as I said, as guidelines for safe practice for the clinical ketamine community. So worth knowing about this document. And just to sort of summarize, in essence, in this document, I outline that in a clinical ketamine treatment, there are 3 important roles. There's a medical professional who is being attentive to the patient's medical and physical safety. There's a mental health professional. There needs to be a mental health professional who is attending to the patient's psychological well-being before, during, and after ketamine administration. And then, of course, the third role, and probably the most important one, is the patient, who is responsible for communicating clearly and honestly with their clinical team. And so everybody has a job to do. It's possible that 2 of those roles could be in the same person. If someone is a psychiatrist or psychiatric nurse practitioner who has both medical and mental health training, then they could be one person taking on 2 roles. But all that to say that it's very simple. It's meant to be skeletal. It's meant to be spacious by design. I'll tell you about the history of it very briefly. I started working on guidelines for the ketamine community in 2017 with a group of other experienced ketamine providers from a variety of backgrounds. And the document that we were working on got way too long and way too detailed as we tried to describe different ways of working with ketamine safely because of these different approaches that I outlined at the beginning of this talk. And I realized at some point that what I wanted to write was the essence of what was important for safety, not the technical administration guidelines, which can be found in other places, but rather that I wanted to address the ethical components of what was needed to keep patients safe. So I think this document does a good job of that. And so please take a look at it. And I'm delighted that it's being utilized at this time. I think that's all I want to say about that. Let's see, I got 8 minutes left, I think. Let's see here. So let me change my attention to something else. There are a couple of critical questions right now in the field, a couple of really important topics that we should be looking at right on the cutting edge. So one of the critical issues is this question of, is it possible to extend the benefit or the duration of the beneficial effect of ketamine treatment, because it's sort of short lasting. It's, on average, I mean, it varies for people, but it can be a few days to a few weeks. Sometimes you get a few months if you do a series. But in essence, when ketamine works for someone, some patients are inclined to keep coming back for ketamine over and over again. And there's concerns about the long-term health consequences of that. It can be very financially beneficial for the provider, but is that really in the patient's best interest? And I think what we need to be looking at are a couple things. Number one, this is a question, can we extend the interval of benefit by combining ketamine administration with psychotherapy? Can we utilize the neuroplastic window that opens with ketamine treatment, when synaptogenesis is it's like triggered and when it's happening, can we use that very fertile window to help patients learn new skills or to develop insight about themselves or do something that's going to result in long-lasting behavioral change? And I think that we can, and you know, thousands of clinicians independently who are having a converging finding, they can't be wrong. But what we need is we need more rigorous scientific studies that looks at this. Psychotherapy is inherently a difficult variable to study. We know that. But I think this is right where it's at right now. So that's the first thing. What else? Another question that we have is if we give a slightly higher dose of ketamine, if we go beyond what was in the early scientific literature, if we go above the recommended 0.5 mg/kg dosing infusion strategy, if we go above that, is there any additional benefit? And I think that for some patients, there is more benefit. Some patients really benefit from ketamine facilitated psychotherapy, so concurrent talk therapy. And some patients, not all of them, but some patients really benefit from psychedelic ketamine journeys or psychospiritual exploration that is induced by ketamine. So not everybody's a good candidate for this. Please consider taking a training if you want to talk about this in greater detail. But here's the thing. I think I've said this to this group before. I've been studying this topic for 20 years now, and I still have contact with patients who say that their ketamine facilitated psychotherapy, where they were untying knots on the inside using ketamine and therapy combined, or patients who got psychedelic ketamine exploration who did that. Some of them say that that was at the top, I want to say in the top 10, but that's not even true, in the top 3 of the most impactful, most meaningful, most informative experiences of their entire lives. And at first I thought this was sort of like a fluke, but now that we're hearing this more and more and more, it seems incumbent on us to study this phenomenon rigorously and to try to understand what's happening. Who makes a good candidate for psychedelic ketamine treatment? What does preparation look like for this to be psychologically safe? And what is the longitudinal sequelae? What happens over time when you think about ketamine, not just as a medication, but as a tool for personal exploration? What happens if we change our thinking about it and think about it in different ways, and we start asking the question to look for longer lasting impact? So I think that's right where we are on the cutting edge of this field, and questions that I hope we'll continue to talk about. A couple of other questions that I have that I'll just name here as we wrap it up. Another question has to do with the fact that depression is an umbrella term and actually encompasses a number of different things, a number of different disorders or challenges with different etiologies. Some people have organic depression. Some people, it's really a combination of trauma that looks like depression, sleep disorder that looks like depression, illness or inflammation that looks like depression, inverted anger that can't be expressed that looks like depression. And the question that I have is, does ketamine treatment work equally well for different etiologies of depression or not? And I'm beginning to think that it doesn't, and that there needs to be a really careful differential diagnosis on the front end. I don't think we should be giving ketamine to everybody who presents with depression. I have some concerns about that. So that's a question on the cutting edge. Another question from the cutting edge is this. We tend, as providers, we tend to conceptualize psychiatric and psychological care from a very individualistic perspective. We treat one person at a time usually, and we think about their individual problems. But my question is the planet is in crisis, the world is sort of in crisis. Are there ways to use ketamine and other medicines like it for communal healing? something that benefits the community and where the emphasis isn't on the individual, but where we think more about the collective, about ourselves in tribes and families and neighborhoods and communities. Is there anything we could do with that? So that's a question that I have. A couple of other things. Up until this point, the body has been largely ignored in ketamine treatment. We tend to want patients to be still. I don't know why that's the gold standard or the ideal, but the truth is that ketamine can be a very, despite its paralytic and I can't think of what I want, but despite its anesthetic properties, it also can be a very sensual experience. That's something that we haven't talked about much in ketamine treatment. I do think there's something there, how we can use this tool to enhance people's awareness of their own bodies or even their enjoyment of their own bodies. So there's something there that's been missing about the somatic experience that I think we should bring attention to. Two other things. Another thing that's really interesting is the question in ketamine treatment about the critical variable, which things make the most difference? Is it the degree of dissociation or the length of exposure? Or do different patients benefit from different things? I have more to say about that. I'll save that for the Q&A. I think that's a question that needs to be explored. And finally, we come to the last thing that I think is, the last sort of burning issue, which is there any value in ketamine facilitated experiences for people who are not having symptoms of a psychiatric disorder? In other words, is there any value in ketamine as an adjunct to psychotherapy or in psychedelic ketamine exploration for people who are functioning reasonably well? I think at this point, it's difficult to make the argument that it's not safe. And I'll tell you why. Okay, we've established that ketamine is considered a very safe medication when utilized in a supervised setting for all kinds of medical emergencies and crises, and for people who are medically fragile of all kinds, babies, older adults, roadside accidents, etc. So I think that's been already addressed. We've established that ketamine is not only safe, but also helpful in this particular dose range for people who are psychiatrically fragile, people who are suicidal, people who have hard to treat refractory depressive disorders, bipolar disorder, refractory MDD, etc. It becomes difficult at that point to argue that ketamine is somehow not safe for people who are considered well to begin with. That makes no sense. So I think there's something there that needs to be explored and a very fruitful area for research. Let's see here. I think that was all I wanted to say for right this second. Let me just again, just reiterate that if I've piqued your interest in this fascinating topic, I hope you will consider taking a training for clinicians. Again, I'm not training, but please take a look at that. And last but not least, I have a website with just tons of free resources, free stuff for your patients, free resources for clinicians. I hope that you will make use of that. I put it there for free to help you. So again, that's kriainstitute.com. And with that, thank you so much for listening to this talk. I would be delighted to take some questions.